of what we will be talking about today. So we will discuss what neurological visual rehabilitation is, what's the difference between visual efficiency and visual information processing, the role of vision therapy in both acquired and traumatic brain injury, so its cause, its pathophysiology, and most common visual symptoms that you see in your patients with TBI or ABI. We will also be speaking about pediatrics in some certain case studies about autism, ADD, ADHD, so attention deficit disorder, and giving you some case examples about them and how neurological visual rehabilitation can help with the symptoms and the underlying visual issues in those patients. We'll also be talking about how to, the steps of doing visual efficiency versus visual information processing evaluations. And then we'll open it up to Q&A. Okay, so neurological visual rehabilitation is known as vision therapy to patients. It's basically an individualized treatment program that is prescribed to alleviate conditions like amblyopia, strabismus, accommodative paresis, convergence or divergence issues, motor coordination, visual information processing deficits, and other learning-related problems in pediatrics. So it benefits both pediatric adult and geriatric populations, as well as special populations and patients with developmental delays. So we always start with visual efficiency, and we're going to be talking about the etiology and then the most common things that you would see in a patient that has an underlying visual issue, so those three are convergence insufficiency, accommodative paresis, and saccadic dysfunction. And we will see just how common they are in adults versus children. So starting with why why there are symptoms, why patients come in having all these different symptoms. And so the first thing is ocular misalignment. And so when the eyes are not working together, they're not working in sync as we are reading or tracking something, or if one eye is too blurry, so the brain shuts it down and you're down to just one eye. And so that causes a lot of issues. Neurological visual deficits as well cause in asthenopia or visually induced trigeminal dysphoria. And so the symptoms that are put under the umbrella of asthenopia include headaches, eye strain, dry eye sensation, neck and shoulder pain, a lot of your eyes feeling overworked, not being able to be on the screen or doing near work for more than about 15 minutes before feeling these pains, sometimes less. And so we first start by using prisms or lenses to decentration in vision therapy, and we combine it with active vision therapy to overstimulate the trigeminal nerve and alleviate those symptoms of asthenopia. So convergence insufficiency, just like the picture here, it's basically poor eye teaming where the eyes overcross, and so the convergence is not accurate at any given distance, and it interferes with the person's ability to read, to see, to make sure things aren't double and they're not moving around as they're trying to look at a paragraph or anything up close. And so you'll see with the picture, with good eye teaming, both eyes would come into a specific point at that distance that the target is held at. And that will allow the eyes to be precise and to be able to see things not doubling and with no discrepancy. But with poor eye teaming, and especially for convergence insufficiency, there are a lot of different, divergence insufficiency, convergence excess, divergence excess. The most common is convergence insufficiency. And with that one, the eyes over-converge. So they're actually converged a lot closer than where the target is. And that creates double vision. As you see here in this first image, the one eye would be looking in one target, the other would end up looking somewhere else. And then how big that discrepancy is depends on how what the numbers are and what the magnitude of convergence insufficiency is, but it ranges from blur, which is just a little bit of overlapping with letters, to complete diplopia. Common symptoms for convergence insufficiency: difficulty concentrating, difficulty reading, blurred vision and headaches, ocular fatigue, words overlapping, and feeling sleepy when reading because the eyes are using so much energy just to read that the entire body gets tired. And so in America, we have vision screenings that are mandated by each state, and each state has different laws. But basically, it says that K through 12 schools, there are certain grades that have to be screened in the schools, and a report has to be given to see whether or not these children pass a vision screening. If they don't, then a letter is sent home to the parents telling them that your kid failed the vision screening, you need to go see an optometrist. However, the screening is very general. We're just doing the, can you read a chart at distance? And so I have been doing vision screenings in schools, and there's a big difference between seeing 20/20 and having visual efficiency issues. So a child that sees double or blurry or overlapping can still pass this vision screening. And so that double vision can look like those two examples right here. It could be a halo around it. It could be complete overlap, where it could be even more double than that, where they see two words next to each other that's the same word. So they're very separated. Double vision can be horizontal, vertical, it could be diagonal as well, just depending on what the misalignment is and where it is in the visual system. Okay, so that's saccadic dysfunction. The next most common thing is the accommodative paresis. And so this is a sensory anomaly of the visual system. It has nothing to do with being fully corrected in contact lenses or glasses. It's not from the front, it's from the back. It's an eye-brain relay issue. And so a patient can be going regularly to see an eye doctor and being fully corrected to 20/20, but still have accommodative paresis. And so there are two subcategories under it, accommodative paresis. The first one is called accommodative insufficiency, and that is the inability to sustain focus and clarity when looking at a near object. And so that could look like intermittent blur for a patient. They can clear it at some point, but sometimes it just goes blurry. They don't know what's making it blurry and what's making it clear. It just, maybe they look away for a minute and come back and it's okay, or they blink, but it's inconsistent. The second one is accommodative infacility. And so accommodative infacility is a lack of neuroplasticity when shifting focus between distances. So for example, in a classroom, copying from the board and having to quickly glance up, find your place and get it clear, and then find your place where you were writing and keep that clear and keep switching distances. A lot of that happens in classrooms, in school or college, where the student has to sit in the front, or every time they look up, it's blurry, but up close, it's okay, or vice versa. And so that's the infacility portion of it. So common symptoms, like I just said right here, is intermittent blur when shifting focus or near, a lot of frontal or temporal headaches. So anywhere where the visual system is being overused and fatigued because of this visual efficiency deficit. Ocular discomfort, where sometimes the patient can't really explain what's going on. It's just uncomfortable vision. And then double vision, motion sickness, and loss of concentration during a task. And so this is an example of how bad blur can be when someone switches focus between distance and near. It more often happens up close than far away. During the switch, that blur is increased up close, but it could also happen at distance. And when you are copying back and forth with accommodation, you also usually patients also have saccadic dysfunction and accommodative insufficiency or infacility at the same time. And so, imagine trying to be in school, having to copy something from the board, not being able to track where it is, so consistently losing your place looking at the board. And then on top of that, it's blurry. And then you're switching back to near where it is blurry and you can't find your place. And so it becomes very difficult. It really hinders patients from achieving their potential in school or college or work. And so this right here is just kind of a diagram of eye movement disorders with ocular fixation, pursuits, and or saccades. And so with saccades, our eyes are supposed to make very precise movements where we're looking at one target or word, our periphery anchors ourselves in where to go next. And it takes less than a second. This is just automatic. And then we make one smooth transition from one target to the next without stopping in the middle, without overshooting and coming back to it. And so, and then we keep reading. If there is an issue where somebody is undershooting, where they're stopping in the middle, their eyes are taking an automatic break and then moving on to find the next word, or if they are overshooting and then zigzagging back every time they read, it causes a lot of issues with comprehension, with slowness in reading, with hating school, not liking to take, literature or history or anything that takes, has a lot of reading, even word problems and math. And so, adding that to blur makes the entire, school or college or work environment just awful. So common symptoms, slow reading or loss of place when reading, having to use your finger or marker when reading. So that, just like we said, ends up with decreased comprehension. The patient spends so much time reading a paragraph and trying to stay on the same line. By the time the paragraph is over, they have no idea what the content was, what they just read, because they were focusing on the technique of reading and not on the content. And so frontal headaches, and sometimes it leads to chronic headaches in adults as well. Ocular discomfort and fatigue with near tasks, poor sports performance as well. So clumsiness, lack of coordination. I see it a lot in baseball athletes, unable to bat and hit the ball and anticipate it coming. The reaction time is a lot slower. Or just inaccurate. So they either bat too fast or too slow. Catching a ball, passing a ball, making those quick decisions on the field or court. And then difficulty with math as well, because it's not just the content of reading that is shot, it's also number alignment, because when the eyes aren't looking precisely where they should be, then everything is kind of going to move a little bit. If it moves on the page, or if they're just not able to align it, then they're also going to have problems with math. A lot of patients in the school, K through 12, that have these issues end up needing auditory help, where if they hear a question, they can answer it. So in class, they're doing great because they're using another sense, but they can't do a test, on a test, their grades are very low. And so that's for teachers, when I do lectures for other professionals and, speech therapists, teachers, occupational therapists, we always talk about, well, pay attention to the student, in your class. Is he you're answering all your questions when you're talking to him, but then when it's on paper, it's a problem? That will raise a red flag to let you know there's something going on in his vision. All right, so moving to neurological link to vision. So as you know, you see with your brain and not your eyes. And so if there's traumatic brain injury, then it's going to cause a lot of visual issues. And so we'll be talking about traumatic closed head injury and concussion under traumatic brain injury. We will be discussing stroke under acquired brain injury, and then attention deficit disorders and autism under the pediatric population. So in general here, just the types of acquired brain injury. So acquired brain injury is really the big umbrella that everything falls under. So you have external and internal causes of ABI. For external, so that would be trauma. So that's where TBI falls in, to open or closed head injury. And then with internal, it would be like a CVA or an AVM or surgery complications. So a lot of different things can happen that lead to ABI or TBI. With TBI, the etiology here, looking at closed head injury and concussion, falls are actually among the top, 28% of all traumatic brain injuries occur because of a fall. So, whether it's an elderly patient that just loses their balance and hits their head, whether it's different sports, falling from sports injury. The second one after falls is motor vehicle accidents. And so, motorcycle accidents are among the top in traumatic brain injury, but also car accidents, really anything that shakes the head, anything that causes a coup anywhere in the head. And, unfortunately, traumatic brain injury is what's called a silent epidemic. And so we hear a lot about MS, breast cancer, HIV, and, there's a lot of advocacy for it. But if you look at the numbers, and of course, these are very important, very serious things, diseases, but if you look at the numbers of how many people have traumatic brain injury versus these other issues, it outnumbers everything else. But we're not really talking about it and advocating as much. Thankfully, the last couple of years, I have seen a shift in talking about that in sports, especially American football, hockey, any high contact sport. So there is a little bit more of it now, but it's still not advocated for research is not as extensive as some of these other diseases. So just quickly, a quick pathophysiology here on TBI with closed head injury, anything that, you have the coup and then the counter coup. So the brain, if it's hit from the front, the entire brain is going to shift and hit the back. If anything hits the back right here, this is where the visual, everything that we see, this is where it ends up. And so the visual cortex, any damage to it will cause traumatic brain injury. It could also be side to side. If someone gets hit with the ball in one side and it moves to the other, there still may be some of the neurology there for vision. So etiology of traumatic brain injury, high contact sports and falling, any injury that shakes the brain, these are the most common etiologies. Ocular symptoms here, so accommodative dysfunction, convergence insufficiency, and saccadic dysfunction. Those are the three that we talked about earlier. They are also the most common in TBI. And then concentration difficulties, especially with things up close, and photophobia. So being very sensitive to light, having to wear sunglasses even indoors, for example. Closed head injury, so the coup and counter coup that we talked about with motorcycle or vehicle accidents, and any other trauma like in sports that would cause that issue to the brain. Most common symptoms there, so 90% of patients that have closed head injury suffer from some sort of visual efficiency dysfunction. So whether it's accommodative, it's saccadic, it's convergence insufficiency, it's something, 90% have something there. And 82% feel overwhelmed in a busy setting. And so now we're talking about information processing and how fast visual stimulus is processed in the brain. And so patients come in saying, I used to go shopping, no problem, but now I enter a grocery store and all the colors and all the cans on the shelves are too much. I actually can't pick out my one can from everything else. It's overwhelming. I feel like I just need to leave and go somewhere quiet. A lot of people also notice a shift. They can't go to the airport or sit in traffic anymore. They they can't go to a place that has more than a couple people. It can't be a big party. And so they just feel overwhelmed. 55% of patients have diplopia or double vision or eye strain. And then 33% have headaches, experience headaches with near work. And so they can't work for long periods of time like they used to, especially if their work demands that they do something up close or they're looking at the computer a lot, then they have to take a lot of breaks. And so they're not working as efficiently as before. And then with concussion, so the etiology here is the high contact sports. We've seen it a lot in boxing and other sports, falling or any injury that shakes the brain. So same thing here for concussion. The most common symptoms here: accommodative dysfunction, convergence insufficiency, saccadic dysfunction, and concentration difficulties and light sensitivity. So very, very similar ocular symptoms. All right, so how can we help these TBI patients in vision in our portion? So neurological visual rehabilitation treats all these asthenopia and ocular trigeminal dysphoria symptoms. We of course have to start with a regular eye exam, get them to be in their best correction. So spectacles, contact lenses, whatever is necessary to get them down to their best vision at distance and near. And then from there, we would start using prisms as necessary. Sometimes the double vision is so large that you can't go straight into active vision therapy. You have to give them a little bit of help first. And so you can do some prism and then taper it off during therapy as their eyes get stronger. And then we would start with vision therapy or neurological visual rehab. And so it treats any underlying eye teaming and visual information processing issue actively. And we're basically rewiring the brain after the insult in order to correct any processing of visual stimulus that's lost to injury or disease. And so I find this Abi Tbi checklist very helpful in my first contact with the patient. I just add it to all the other paperwork they're doing when they're coming in for regular exams, not for vision therapy, to see if we can, so I don't want to make sure that people don't get overlooked and they may not think that this symptom has anything to do with their vision, so they might not even bring it up in a primary care exam. But this checklist actually allows them to say, oh, okay, so having headaches could be related to vision, and then we can discuss it further while they are in the office. And so I will share this checklist after we're done on the chat. And so it is a highly accurate checklist in predicting the presence of a visual dysfunction. And basically, if the patient puts anything as always, so it's asking the question and how frequent they're feeling these symptoms, and it goes from never to sometimes to often to always, and they just circle it. If they circle anything as always, that should flag it for you that patient needs to be that conversation needs to be had about their traumatic brain injury or ABI. If they circle 3 or more of anything else, like except for never, of course, so sometimes or often, then that should flag it, even for your front desk staff, to tell you, here, we need to actually discuss vision therapy with this patient. All right, so moving on to stroke. With stroke, we have just a brief physiology here: hemorrhagic and ischemic strokes. So with a hemorrhaging, so 2 different ways that this can happen is blood leaking into the brain or blood supply that is stopped by a clot. And so that area is not getting the oxygen it needs and the nutrients. So with internal ABI, looking at stroke here, the most common ocular symptoms that a patient experiences after a stroke, 87% of patients experience visual efficiency dysfunction. So just like we talked about here, eye tracking, eye focusing, eye teaming, some sort of issue with both eyes not functioning together as a team. 67% have a visual field loss. And so now there is a difference between permanent visual field loss, so when we're looking at a hemenopsia, and visual neglect. Visual neglect, when you actually get them onto the, the Humphrey or any visual field instrument screener, they actually show that they're fine. They're not missing anything in their vision. But then you see them and they tell you, when I eat, I actually don't see the left side of my food. I think I'm done, but somebody points out that I haven't eaten half of my food, or they're not groomed, properly on one half. They only shave one part of their face, things like that. And so it's something that we can actually help with in vision therapy, because it's not permanent damage. It's not a hemenopsia or a permanent vision loss. So there is a difference. Clumsiness also, they're always, walking around, and the furniture hasn't moved in 20 years in their house, but all of a sudden now they're always hitting it with their left leg, or, they're clumsy and they weren't before. Ocular motor dysfunction, so reading difficulties or feeling overwhelmed in a busy setting. 57% of stroke patients feel that they have some sort of degree of that symptom. And accommodative dysfunction, 13%. And so with stroke patient recovery, there are multiple residual effects, and it's not just vision, of course. And it could take up to 2 years after the stroke until the patient is stable enough to begin vision therapy. But it really varies between patients. Some patients recover a lot faster, and it really has to be, this is, a case by case. But it could take up to 2 years before you're able to do any sort of visual issue help with that patient, other than primary care exam and getting them in their best correction. So the neuroplasticity continues over the patient's lifetime. We used to think before that there was what's called a critical window. You can only do vision therapy on kids, and if they are more than 13 years old, it's too late. But it's not the case. Many studies have shown that the neuroplasticity, you can actually rewire the brain throughout the entire lifetime of a patient, a human. And we see that a lot with adults after a brain injury. So we can actually reteach accommodation and saccades on a 60, 70-year-old, the neuroplasticity is there. Of course, it's not going to be easy. It's not like you have a 7-year-old and you just give them the tools and they know it. It's going to take a lot longer. There are also other variables in a stroke or traumatic brain injury that around everywhere else in the body. So it's not just vision, but it's still possible. And then the last thing is neurological visual rehabilitation should begin as soon as patient is stable, which means you have to follow up with the patient frequently to figure out when that stability is, when does it begin. And that stability is not just physical, it's also his or her motivation, emotional. So if they are ready and motivated to begin, and physically their neurologist, their primary care doctor gave the okay that now they are stable, then you can begin. If everything is fine in their body, but they're just depressed, or they don't think they can see again, they're just in a dark place mentally, then it's not going to be helpful, because they're not going to be as compliant with the home exercises. All right, moving on here to pediatrics. So we're looking at attention deficit disorders. Many children with vision, learning, and processing deficits are diagnosed with ADD or ADHD. Some are given medication to help them gain their focus again, decrease the hyperactivity. And so true ADD and ADHD patients frequently have accompanying visual information processing deficits, and those deficits are seen in behavior, and so in academics and sports. So that patient is always fidgeting. He doesn't like to do homework. He doesn't like to read. He doesn't. He wants to make jokes in class. He's always looking outside the window and not at his work. Some of that stuff could not be just ADD. It could actually be because, well, he's blurry. He's seeing double, but that's how he's seen his whole life. So he can't tell you I'm seeing double. He thinks everybody sees the same way. And so there are a lot of underlying visual issues that could be taken care of with those annual exams if the optometrist is paying attention to binocular issues in their exam. The second portion that is related to ADD, ADHD is visual information processing. And so that processing, the reaction time of what they're seeing, being able to notice different things like spatial recognition or visual discrimination, visual closure. So a lot of skills that overlap with occupational therapy could be fixed with neurological visual rehab, and you will see a huge difference in behavior in that patient later, even if they are true ADD. Now, some patients are misdiagnosed with ADD, ADHD because of just by symptoms, and those symptoms are sometimes completely eliminated after vision therapy, where all of a sudden that patient does not need medication, is not ADD. And so, it's very frustrating to see those being overdiagnosed with ADD for children when they may not even have it. So this is a case example. One of my patients, 7-year-old male, he didn't have any significant developmental history. He has 20/20 vision, so he passed his vision screenings in school. Nothing was flagged by the screener. He came in with slow reading. He was disruptive or lazy in class. His mother and teacher were both frustrated and concerned that he will be held back a grade because of his behavior. And so he was diagnosed with ADHD, and he was on medications for 6 months before he came into the office and I saw him. We did a binocular visual evaluation. He did end up having some visual issues, and so he needed 30 sessions of vision therapy. Once those 30 sessions were done, and every 10 sessions I actually do a progress check, and he was progressing very rapidly. After the 30 sessions, it turned out, no, he did not have ADHD. He just had visual issues, and he was frustrated with them, and so it showed in behavior that was mislabeled ADHD. And so all of a sudden that patient does not need the medications that he started on at 7 years old, and he was fine. He's going back to school. He's functioning well. He's not angry anymore, so he's not disruptive or lazy in class. So it makes a huge difference in the potential of these students and patients. All right, so that was ADD. Does anyone have any questions so far, or should we leave it to the end? Okay, so talking about autism now, the most common signs in autism are accommodative paresis, convergence insufficiency, and visual information processing. And so with visual information processing, it looks like visual motor issues, sequential memory, visual closure. So if you give a patient a picture that has parts of it missing, our brain is supposed to just be able to fill in the blanks, and we can know that this is a picture of whatever it is, a duck. With autism and visual closure issues, the patient is not able to put those things together or fill in the blanks. And so that causes a lot of issues in response and in reaction time. Figure ground as well, being able to pull something out of a visually noisy setting or a busy setting, being able to pick one thing up or one shape up from a bunch of other shapes that are around. And then poor eye contact. And so one of the main things that parents notice is my child isn't looking at me when I'm talking to them. And in a lot of cultures, as you know, that's you look at me when I'm talking to you. And so they are actually looking in autism. So autistic patients have a better peripheral vision than central. And so they see you clearer if they are using their periphery. And so they are looking at you. They're actually trying to look as clearly as possible, but it's not the social norm to not, to use your periphery to look at someone. And that, that is something central vision can be strengthened with neurological visual rehab. Now, with the symptoms that are, these symptoms are eliminated, and there's a wide spectrum of autism. And so a lot of different patients and behaviors fall under the same umbrella, but they actually all benefit from vision therapy, some more than others, depending on where they are on the spectrum. But that evaluation, that initial evaluation to pinpoint what's going on is key to see who we can benefit. So here's another case example here, 10-year-old autistic female. She was undergoing physical and speech therapies when her mom brought her to do a visual evaluation to see if she needed any help. She was unable to sit still or look at an object when prompted, and that was always attributed to autism. We did an evaluation, so it was actually both a visual efficiency and an information processing evaluation. It turned out she had deficits in both. And 40 sessions later, she graduated with a dramatic improvement in her behavior. She was tolerant of others. She was able to make eye contact with her mom, her classmates, because now her central vision got strengthened. And a lot of those behaviors that were originally attributed to autism decreased severely, because it wasn't just autism, there were some underlying visual issues. The other thing that was notable here was that her speech and occupational therapists saw an improvement and an increased speed in responsiveness in their own therapies once she started doing vision therapy along with the speech and occupational. And so it's an interdisciplinary team that needs to be there for each patient in order to get a holistic view. And so I talk a lot, I'm always in communication with speech and occupational therapists if the patients are seeing them. And we're always trying to coordinate things that we can do in both of our offices in order to increase the, how much vision therapy is being done. So sometimes I have the occupational therapist do some activities that I have prescribed with the patient so she can get more exposure over the week. And so it's just a great team. It's really good to have other professionals in your team as you're seeing patients. All right, so talking about the overall process here, like we said, we want to do the comprehensive vision exam first. You have to rule out anything else that's going on, especially with traumatic brain injury. So you have to get the MRIs, visual fields, everything needs to be ruled out first, any other disease, before we move on to visual information processing and visual efficiency evaluation. I always do the evaluation first, even if I know that most likely they're going to have, these battery of diagnoses based on their symptoms, because I want to make sure they're a good candidate. I want to make sure there's a good prognosis for them to actually succeed at the end of this customized vision therapy program before we even start. I don't want to waste their time, their money. If they're not a good candidate, then we can stop at the very beginning. After the evaluations, I usually write an analysis report and I send it to the patient, and then I send it to anyone else working with the patient. So their neurologists, their speech and occupational therapists, primary care doctor, physician, if they're interested. And in case of pediatrics, I also send it to the school. And so then everybody is aware of what's going on with that patient. After the result analysis, we would be doing a neurological visual rehab sessions, and they're usually prescribed once or twice a week, depending on the case. And then the rest of the week, the patient does home exercises. And that repetition of home exercises is key in order to learn a new skill. So it takes the visual system about 10 weeks of repetition to learn a new skill. And that's why every 10 weeks or 10 sessions, I do a progress report. And so we're looking at their, comparing the data to baseline for that person to see how he or she progressed themselves, and also comparing the data to age norms. And I write a report at that point as well, a progress report, and send it to the parents or patient or professionals. So when there's incompliance with the maintenance, the home activities, it really prolongs the entire process. You just like physical therapy, if somebody breaks their leg, goes into physical therapy once a week, sits on the couch the rest of the week, nothing is going to get fixed. So it's the same idea. After they graduate their program and when they hit all their goals, there still needs to be some sort of maintenance home activities and follow-up for at least 4 months post graduation. So I usually do a 1-month follow-up and a 3-month follow-up after graduation. And for both of those follow-ups, depending on how they do, I start decreasing the amount of home exercises. And so you have to taper it off in order to prevent regression of these newly learned visual skills. If everything looks good by the 3-month follow-up and there has been no regression, there most likely will not be any. So you can actually take them off of the home exercises at that point. Okay, so here is just quickly going over what a visual efficiency evaluation entails. So it's important for daily living, like sports, driving, work, school. And so we're looking at different visual skills like depth perception, ocular teaming and tracking and focusing, ocular accuracy, any strabismus or amblyopia, visual fields or visual neglect, eccentric fixation. And so, pinpointing what's going on will really give you an overall idea of where are the points that you can actually help with. Are there some things that are just permanent and the patient has to have realistic expectations about them? What's going on with the visual system other than being best corrected. And again, having 20/20 vision has nothing to do with the visual efficiency issues. You can have 20/20 vision in each eye, but having each eye not even work together. Okay, so for visual information processing, so this is an evaluation and battery of information processing tests. This is usually done on a separate day. And so it takes about an hour and a half. So I can't do the visual efficiency and this one, the patient will be fatigued. So they won't be able to give us accurate information. And so usually we start with directionality, laterality, letter and number reversals. This is also on adults because after a stroke or a traumatic brain injury, some of these things could be lost. So this is not just for kids for letter reversals. Fine motor control, so their ability to quickly manipulate a task and quickly make choices. Visual motor integration, so integrating their fine motor skills, hand-eye coordination, writing, their penmanship, spacing between words, visual memory, visual discrimination, and visual attention. So after the evaluation, I usually do a patient or parent consult. I give them a summary of the findings and my impressions and recommendations for the classroom or their work environment to make it better until their eyes are strengthened. So these are just different accommodations in the classroom or workplace. And then the report can be shared with all providers that the patient or parent approve. Okay, so it's also, this is the interdisciplinary rehab team that I touched on earlier. So it's a team of everyone that has to do with neurology in order to get the full picture and share data between different professions so we can have the patient's best interest in mind. So, neuro-optometrists, ophthalmologists, neurologists, vestibular therapists, speech pathologists, occupational and physical therapists, psychologists, internists, the school teachers, and of course, the parents or caregivers. So the benefit of this interdisciplinary collaboration is that it widens our professional scope of knowledge. We gain a holistic approach that dramatically enhances patient care and give us the ability to provide the most comprehensive patient care and prevent symptom remission. So everything I've learned in optometry school, gave me enough to begin vision therapy and see patients. But what I've learned from other professions and the patients themselves is a lot more than a university can offer, because now it's more of experience. You're now looking at different things that might not be in your own scope of practice, but now that you know about it, it gives you such insight about your own patient and what's going on with their body, their vision, their mental health. So it's really important to do that. So what can you do? The first thing is the acquired brain injury symptom checklist. It's a very easy way to pinpoint the patients that are in need of help. Spread your knowledge, educate about neurological visual rehabilitation. So like I said, this paper is always added into all the paperwork of a new patient. Existing patients, we're always asking them about key things like double vision, headaches, blurred vision. And it doesn't take much out of your chair time to add this, because this is something that they're doing at the beginning and you're just reviewing it quickly, just like you look at their history, their patient history. All right. And I think there may be some questions in the chat room.
Thank you indeed, Dr. Almouradi. It's really a pleasure to, and it's really a moment of learning from someone who has quite a big background. Merci beaucoup, Dr. Almouradi. C'était un moment d'apprentissage, un moment pour nous de réflexion aussi. Beaucoup de termes nous échappent, il faut le dire honnêtement, parce que les cursus diffèrent. Je voudrais, avant d'entamer un petit peu les feedbacks des personnes qui sont présentes, c'est de vous poser quelques questions sur, d'abord, it is taking a huge amount of time. The number of sessions, it's quite very high. So I have 40 sessions, 30 sessions.
Yes.
How do you set up your clinical work? How do you organize yourself? Have you some people helping you, such as assistant and so on? This is the first question. The second is, it is really a co-management issue.
Yes.
So you have to exchange a lot of files, reports, and so on. So this is also taking a huge amount of time. If you don't mind, I would like just to ask you, when you have finished your graduation, how long it has taken you to get all these abilities on neuro-optometry? Je vais expliquer en français parce que ça prend beaucoup de temps pour faire toutes ces sessions. Alors, la question qui était posée à Dr. Mordi, c'était comment vous vous organisez pour faire, comment organisez-vous votre clinique, si vous voulez. Est-ce que vous avez des assistants? La deuxième question, c'était, étant donné que c'est un travail de co-gestion, de co-management, où sont impliqués différents praticiens, ça prend beaucoup de temps aussi pour faire préparer le document, envoyer aussi les rapports. J'ai vu qu'après chaque 10 sessions, il y a un rapport qui est envoyé un peu à tout le monde. Et puis, la dernière question, c'était à la fin de votre graduation, combien de temps ça vous a pris pour avoir cette formation? Là, c'est les questions que j'avais soumises au Dr. Almouradi. Donc,
okay. So the organization part, I work in 2 different offices, and each office has 3 other optometrists that are primary care. I'm the only one that does the vision therapy portion. And so they are, 5 days a week, 6 days a week, they are seeing patients, adults and pediatrics. And then they're the ones that are making the recommendations based on their primary care exam as to who needs that evaluation for vision therapy. I do some primary care, but it's usually in the mornings, a couple days a week, and I focus on vision therapy the rest of the week. And so you really have to pick one thing. Some people only do contact lenses, for example, and so you can't try to do all of it, because then you won't be mastering one particular niche in optometry. And so the way I do it, it's 30 minutes a day, once a week per patient. It is scheduled the same day, same time for each patient. And so they're just kind of lined up every 30 minutes in the day. And then if they are coming in Wednesdays at 3, then that same patient will come in the next Wednesday at 3 o'clock. And so they are scheduled in blocks. Usually it does not take 40 sessions. For those case examples, it was because there were some developmental delays, and so it takes longer to do. Usually it's about 25 sessions, so 25 weeks per patient. And so, you know, when I first started after graduation, I started with a couple patients, and then primary care was more heavily, you know, into primary care. And then as patients became, you know, we started getting more referrals, then now I just do vision therapy most of my day. And so it's, you know, you can see up to about 14 patients a day in 30-minute slots. And it's the reporting, I usually just come in the morning and do the reports. The more you do it, the faster it gets, because you can develop a template and change, you know, the patient name, and then the diagnoses are very similar. And so it doesn't take as long once you get the hang of it. The other portion is, you know, some patients are done earlier. At some point, which I haven't reached yet, you know, some patients would have to wait. So if, you know, we can have patients on a waiting list until that time block opens up. You know, but I've been able to accommodate most patients because it's 30 minutes. And so everybody for kids wants to come in the afternoon because they want to come after school. Most of the adults come in the morning because after traumatic brain injury, they're not working as many hours or they lost their job. So, you know, this.
On a problème de son. We have, you can't hear. Please do activate your microphone. Okay.
Okay. Was it off the whole time?
No.
Okay.
Because I have set the possibility of other people to ask questions. So.
Okay. Okay. Sounds good. And then the second part of the question was how long it takes to do it and the reports, and then can you remind me of what was the second part?
How long after your graduation?
Yes.
It has taken how long to get to learn all this?
Oh yes, so this is actually learned before my graduation. Neurological visual rehab is part of the 4-year optometry schooling, and so you know, we learn it from first year. We talk about strabismus, about accommodation, and then there are just different courses throughout. The last year, which is the clinical rotations, you get to choose whether you're doing it in contact lenses, ocular disease, primary care, and I chose 3 of the 4 rotations to be in vision therapy, so I can see it in different modalities, you know, so in a hospital, in a private practice, in a VA, a veteran facility, so we can see older patients. And so you actually, and I don't know how the system is, you know, overseas, but over here, when I graduate optometry, it's part of it. I already know it, and now I'm just practicing. There are clinical practice times in our 3rd and 4th year curriculum. So I'm actually seeing patients before graduating under the care of an optometrist, staff doctor. And so once I graduated, I actually began right away. But I think now I've developed a lot more strategies, you know, for time consumption, for you know, customizing to each patient a little bit better, just from experience. But the knowledge was there from the beginning. You know, the technical knowledge was there.
Thank you. So, is there any other questions, René? Yeah. Juste active ton micro. Ouais, voilà, c'est bon.
Yes, c'est fait. Je vais poser la question en anglais, puis après je traduirai également. Thank you for your clear and smart presentation. I appreciate very, very much. Okay. First question, I have 2 questions. The first one is, would you mind to give your point of view about Yogg prism?
Yes. So
for TBI and for concussion.
Okay. So with Yogg prism, it really has.
Sorry.
Go ahead.
Just I translate. Okay. Là, je dis simplement que je le remercie beaucoup pour sa présentation qui était très claire et très intelligente. Voilà. Et puis la première question, c'est comment dire, quel est son point de vue par rapport à l'utilisation des prismes jumelés pour les problèmes qu'elle a présentés, pour les deux problèmes en particulier qu'elle a présentés, donc pour les, comment dire, les traumatismes et les concussions.
Okay, so yoked prism, you can't just put on yoked prism and let the patient leave. It actually has to be coupled with active therapy. And so some of the therapy activities could look like wearing yoked prism and then having a target in front of them that they have to point to. And then the idea of it is that you're rewiring the brain to have them compensate for the deficit that occurred because of concussion or TBI. And so if the patient doesn't have any issues and they wear yoked prism, so if you try it on yourself, and then your brain adjusts. So you will first, if here's a target, you would not touch it. You would be looking, touching somewhere else. And eventually you would adapt to know that, okay, so the image of it is here, but it's actually on this side. And then you would correctly and accurately touch it. But then once you take off the glasses as a non-concussion, non-TBI person, your brain readapts to saying, okay, now I'm looking straight, yoked prism is not on anymore. What studies have shown is that with traumatic brain injury and concussion, the effects of the yoked prism last a lot longer in the patient's brain. And so they're not wearing it all day. They're actually wearing it only during the vision therapy session. Depending on how much they tolerate, they can wear it up to 15 minutes a day during the rest of the week with the exercises. But then when they take it off, it actually will last the rest of the day, sometimes longer, where they are now, pouring their tea in the correct cup. The brain adapts and then kind of holds on to that adaptation post-yoked prism.
Donc, la réponse, en fait, c'est qu'elle n'utilise pas les prismes jumelés à temps complet, comme on peut le faire et comme on en a parlé parfois pour certains problèmes de vision binoculaire importants, tels que des fortes ESO et des fortes exos, qu'on ne sait pas traiter ou difficilement traiter autrement. Et donc, elle utilise les prismes jumelés verticaux, en particulier donc, pendant les activités, et après, de temps en temps, une vingtaine de minutes parfois par jour, ou quelques jours par semaine, pour peut-être renforcer sa thérapie. May I ask you a second question?
Of course.
Okay. Second question, in your experience, if so, could basic archaic reflexes be used, helpful for TBI and again concussion?
Yes, and so primitive reflexes is
yeah.
what you're talking about?
Let's translate. La deuxième question, c'est de demander si l'utilisation donc des réflexes archaïques, la reprise des réflexes archaïques, qui s'intègre bien sûr dans toute approche, développementale, donc chez les optométristes, comportementaux. Est-ce que c'est utile également? Est-ce que ça peut être utile pour les conclusions et les TBI?
Okay, so I usually use primitive reflexes on children so pediatric population with developmental disorders like autism, for example, or Down syndrome. But with adults and traumatic brain injury, that is left to occupational therapy. So in my recommendation section, I would say, if they're already seeing an occupational therapist, then do primitive reflexes. If not, I would recommend them to go do that, but I don't do it in the office for adults.
La réponse, c'est qu'elle ne le fait pas directement. Elle fait faire ça par d'autres thérapistes, enfin d'autres rééducateurs et éducatrices, si toutefois elle juge que c'est nécessaire. Et dans certains cas, évidemment, ça peut être intéressant, mais elle n'y touche pas. Enfin, je pense que c'est peut-être difficile de tout faire, comme elle l'a dit tout à l'heure. C'est difficile de se consacrer à la fois à ça. Tout à l'heure, elle faisait référence à l'adaptation des lentilles de contact et là, pour un autre type de rééducation. Thank you for your answers.
Absolutely.
Hello.
Hi.
Hello, how are you? Hello, Dr. Yaman, how are you? My name is Sarah, and I am an optometrist student from Morocco. So I want to thank you so much for your presentation, a wonderful presentation in which you clarify the relationship between the mind disease also the relationship between the mind and the sight. Thank you so much. It was so clarified. It was so wonderful. Thankful. I have benefited so much information from you actually. At the same time, I want to thank you, Dr. Shaban, for his efforts that he makes for us, for all the students have a relationship with the field of optometry and contactology, and all the followers, identify all the followers in that field as you. We recognize you because of Dr. Shaban. Also, I thank you so much from that this opportunity. My professor, Ronnie Comp, he's my professor. I thank him so much for his questions that he put for our benefit, to benefit more than these questions that he had put for you reply as his questions. Also, I thank Professor and Dr. Wazani, Mr. Razani. I thank him for his presence between us today. So my later word that I can say for you is you are welcome in Morocco any such time. So especially in Rabat, the capital of Morocco, also the University Mohammed VI. So thank you, Mohammed V.
Thank you so much. Thank you.
You are welcome.
Thank you.
Dr. Almouradi. Vas-y, Mohamed.
Thank you, Sarah. Thank you, Dr. Almouradi. It was a pleasure to attend your lecture.
You are welcome, sir.
I would have two questions for you. It's gonna be very fast. So the first one about amblyopia. We had a neuroscientist before a webinar with a neuroscientist here from Montreal, Canada. Was talking about amblyopia and the neuroplasticity over age. So you said in your lecture that the age doesn't matter for the neuroplasticity, but it's easier to work with children or young adults. So what is your age limit in amblyopia? You do vision therapy with them. This is the first question. The second question, do you use video games for vision therapy in amblyopia? And what kind of platforms or video games you recommend to use in amblyopia patients? And thank you again.
Absolutely. Great questions. Yes, so with age limits, I have personally found success in up to 22 years old with amblyopia. And that patient that was, older, I've done mostly 19 to 22-year-olds. Those were, the older patients. They actually had quite a bit of amblyopia. So they were 2100, 2150, and we got them down to 2020. And so in textbook says up to 13. And yes, absolutely. It's a slam dunk for, up to 13 years old, 20 visits, patching with active therapy, done. They're 2020. With 22-year-olds, it took a little bit longer. They were definitely more motivated than kids, though. I didn't have to give them prizes or anything. They just wanted to go to college and see, and both, drive, have that depth perception. So they did their work and they patched. They were able to go down to 2020. I do have a 45-year-old patient right now that is amblyopic. I was able to get her down so far to 2025. It's one line above perfect vision up close, and we're still working at distance. And so it's a little bit tougher because you have to break down that many more years of not using the eyes. And so, there are a lot of different barricades at that point. But I can't really, and from my experience, up to 22, no problem. A little bit older, you know, I'm still working on it. And so I haven't had an amblyopic patient, except the 45-year-old that is older than 22 wanting to come in. And then as far, yes, I pulled away from screen time just this year because all the students are on Zoom all day long for school, and you know, it's damaging to the eyes. And so, but usually under normal circumstances before the pandemic, yes, I definitely do video games. It keeps them engaged, it keeps them doing the exercises longer, it increases compliance at home. And so you know, anything that has, I have red-green glasses, and so also you can do a red-green filter on top of a screen. And so you can really use that on anything. A lot of the things I use that are more paper-based would be like, you know, red text, red-green glasses, you're wearing the red lens over the good eye, and then trying to do an exercise that has hand-eye coordination. If it's a video game where they're using a tablet and they're actually using their hand like a touch screen, then yes, you can do it. If it's on a laptop or if they're using like a joystick, then it's not really helpful because you want hand-eye coordination where you're pointing and touching where you're looking. And so, you know, just be mindful of that when you prescribe. There are different, you know, anything that, you can use any game, really, any game that the patient is interested in, as long as they're patching. So you can patch the good eye and have them use that game where it requires tracking, pointing, touching on the screen, then it's okay. Depending also how much amblyopia they have, that would trigger you to see what games. So if they're still at the beginning stages, you would want bigger targets. So you would want the tablet to be large. You would want the targets to be big. And then as they're getting better and their visual acuity is improving, then you can go down to the normal games with smaller targets.
Okay, interesting. Thank you very much,
Yeah.
Dr. Almouradi.
I have just something to say again. I have heard a lot about NeuroLens prism counters.
Yes.
They had the first system was MD1, and now they have the MD2. The question is, what do you think about that? This is the first question. Je vais la traduire. On a entendu énormément parler d'une société qui s'appelle NeuroLens, qui travaille sur l'évaluation des déficits, si vous voulez, de la vision binoculaire et de tous les aspects qui sont liés à la vision binoculaire. Ils avaient deux systèmes. Le premier, c'est un système qui s'appelait MD1 et le deuxième, c'est un système qui s'appelle MD2. C'est une évolution. J'ai mis ça, il y a beaucoup de vidéos que j'ai mis en ligne, ainsi que des documents que vous pouvez consulter. Ils travaillent sur la base de prismes profilés. Ce sont des prismes profilés qui permettent de traiter, y compris des problèmes liés aux nerfs trijumeaux, notamment les histoires de migraine et céphalée liées à la cystose oculaire. Donc la question que je vais lui poser, est-ce qu'elle a une idée sur cela? Second question, which is a kind of comment. A long time ago, we have heard about using chromatic filters for dyslexia. So that was quite following the work of Hubel and Livingston about magno and parvocellular cells. At the moment, because in your presentation I haven't seen a word about dyslexia. I have seen about difficulties of reading and so on. It could be linked to dyslexia, but do people still use chromatic filters? La deuxième question que je vais poser, c'est à propos de l'utilisation des filtres chromatiques, des filtres colorés pour compenser, si vous voulez, le déficit chez les dyslexiques. Les dyslexiques, ce sont des personnes qui ont des difficultés à lire à une vélocité assez importante. Suite à des travaux qui ont été publiés dans les années 90, début des années 90, qui étaient des travaux de Hubel, David Hubel et Livingston, sur les voies, les deux voies principales qui sont les deux systèmes, si vous voulez, principaux, qui sont le système magnocellulaire et le système parvocellulaire. Donc, c'est un petit peu, si vous voulez, faire le lien entre ce qu'il y avait comme connaissance fondamentale et ce qu'il y avait comme lien avec l'application clinique. Third thing, which I have remembered now, is you are asking people to bring with them MRI, and sometimes you do VFs. The whole point is that I am following quite closely this field because I have attended some lectures of Dr. Lotfi Merabet on the system, on the where and the what system, and the fact that with the MRI we can't see anything when it's quite a very small traumatism, some deconnection, sort of deconnecting wiring, the wiring of cells. So when you have quite a checklist which you are going through, this could be more helpful sometimes than looking at the MRI or the visual field. What do you think about that?
Okay. And do you need to translate the third question?
Oui. Alors, j'ai posé la question, j'ai fait une petite remarque concernant l'utilisation de la résonance magnétique, de l'IRM et du champ visuel chez des personnes qui ont subi des traumatismes cérébraux et qui ont des handicaps visuels liés à ces traumatismes, donc ce qu'on appelle TBI et CVI en anglais. Donc, ce sont des incidences, si vous voulez, une incidence qui est très minime, qui ne peut pas être visible avec l'IRM. Parfois, elle n'est pas visible aussi avec le champ visuel, si vous voulez, donc parce que c'est des choses qui sont de petites déconnexions qui vont perturber, parce que le fait qu'il y ait un choc, on a une sorte de déconnexion, si vous voulez, d'un certain nombre de structures, mais c'est tellement fin, c'est tellement petit qu'on ne peut pas les voir. Donc, la question que j'ai posée, est-ce que c'est nécessaire d'utiliser l'IRM et le champ visuel? Ensuite, puisque est-ce que ce n'est pas plus optimal, plus indiqué, parce qu'elle nous a montré une sorte de liste de vérification, checklist, qu'elle passait à travers, parce que ce sont des questions qui sont tellement intéressantes, qui vont nous mettre en évidence peut-être ces déficits qui sont, si vous voulez, tellement fins qu'on ne peut pas les apercevoir ni par le scanner ni par l'IRM. Voilà, c'est la question que je vais poser.
Okay.
Merci. Thank you.
So for the NeuroLens question, we actually do have a NeuroLens instrument in the office, and NeuroLenses are basically progressive prisms. And so we used to be able to just grind in prism, and it was just the one number, diopters of prism across the entire lens. But now we're able to do it as a progressive. And so you don't need that much prism for looking far away, but you do need it up close. And so there's no sense in putting the entire magnitude of it for all distances. So my thoughts on it, usually I prescribe it to adults who have headaches, chronic headaches, frontal headaches. That has been really the most used out of it. For kids, I like to get to the problem itself via active therapy and fix it rather than just put them in prisms. It's not really meant to be used for strabismus. It's not there to try to help any eye turn. It's actually there to try to help adults who use the computer a lot, or they're reading anything up close for their work environment, and having a lot of visual stress. It's usually base out prism. That's been most successful, and it's just helping converge, and so the eyes don't have to do all the converging all day long in that intermediate to near distance. So it's really good, great technology that we can finally do it as progressive prism, and manipulate what number goes where and how strong we can do it at the bottom portion and the intermediate portion of the glasses. But like I said, really it has been from my experience, it's been helped just for asthenopia more than for misalignment itself. So they could be maybe have a phoria, like mostly an exophoria, and then it's large enough, but they don't want to do vision therapy. They want something that's just a quick fix. Then they can put on the glasses when they're at work.
If you allow me, I will translate this question. Elle utilise le système NeuroLens qui sont basés sur une sorte de prisme progressif, si vous voulez. Donc, étant donné que c'est surtout pour les gens qui ont un stress visuel de près, qui utilisent énormément les interfaces digitaux et les écrans et qui se plaignent de migraines ou de difficultés, notamment s'il y a à la base des phories. Donc, ça aide, ça soulage un petit peu le dispositif naturel que nous avons de convergence pour permettre aux gens de bien converger. Donc, pratiquement, ils ne l'utilisent que pour les adultes qui sont dans leur clinique, ils ont ce système-là qu'ils utilisent. Donc, c'est un petit peu ça la réponse qui a été donnée. You can carry on if you like.
Okay, and so the next question was regarding using chromatic filters for dyslexia. You're correct, there was no dyslexia mentioned in the lecture, and that's because it's different. So there are some of the symptoms overlap between visual tracking, letter reversals, and visual information processing, and the symptoms that patients exhibit with dyslexia. However, they're different. So from the optometry standpoint, we are looking at the visual component of that patient. And so if they have true dyslexia, then we can't really do anything with that portion. We can only help with the, vision therapy can only help with the information processing that is visual, and with, letter reversals that is based on vision. And so it doesn't fix dyslexia. It only fixes the visual component. And that's why it wasn't included. With filters, to kind of look at different, magno versus parvocellular, I have seen that in more of, occupational therapy and people that are speech therapy when they are looking at dyslexia there. But I used any of it myself in the visual components. And, we still got the results without using filters. The only filters I have used were on adults, and not for dyslexia, but more for to decrease the overstimulation after a traumatic brain injury. And usually it was in blue. The blue hue was seen, to be the most calming for patients. So I had a patient that was a nurse, and she was just overwhelmed after her traumatic brain injury in a hospital setting, because it's fast paced, it's very bright, it's, LED white lights everywhere. And so she actually noticed a huge change when she started putting on blue lenses. Some of the motorcycle accident patients definitely benefit from a more orange amber lenses, but it's very different. It's a different use. It's not using it for dyslexia. And so I haven't really delved into the dyslexia portion as much, just because I don't deal with it.
Okay, I translate it before you go carry on to the third question. Pour ce qui est de l'utilisation des filtres chromatiques pour la dyslexie, Dr Almouradi nous dit au fait que c'est vrai qu'elle n'a pas abordé cette thématique, simplement parce que dans son souci, c'était un petit peu pour nous montrer le processus visuel qui l'intéressait beaucoup plus que, si vous voulez, le processus cognitif, etc. Donc, toujours est-il qu'elle utilise des filtres, pour nous, entre guillemets, ce sont un petit peu ce qu'on appelle les filtres thérapeutiques, donc ils sont un petit peu élargis vers autre chose, puisque le bleu, elle utilise le bleu pour les personnes qui ont eu un traumatisme cérébral. Ensuite, elle nous parle d'une infirmière qui a subi un accident, et par la suite, elle était très photosensible parce que tout l'entourage était maintenant avec une lumière qui est assez élevée, en LED, etc. Donc, et là, c'est l'utilisation permettant à cette personne un petit peu de pouvoir supporter cette sorte de handicap et de stress. Aussi, elle a parlé d'utilisation des filtres orange pour ce qui est d'un certain nombre de patients qui ont subi des accidents. En fait, l'utilisation des filtres thérapeutiques tels que les filtres chromatiques, pardon, sont beaucoup plus utilisés dans les thérapistes occupationnels, si j'ose dire. C'est une partie un petit peu de la psychologie, ou bien chez peut-être, je ne sais pas si je me trompe, chez les ergothérapeutes qui peuvent soulager un petit peu ces effets-là. You can carry on for the third question if you don't mind.
Absolutely. So the third question was regarding MRIs and visual fields, and whether or not it was a better gauge of patient symptoms to look at the checklist. And yes, absolutely. So the checklist is key, because whether or not we're seeing something on MRI, if the patient is asymptomatic, they're most likely not going to seek help anyway. And so the other portion is that the visual field, I actually, we do visual fields in office. And so that is part of the primary care battery of testing for the patient. And so I have that on hand, but MRIs, I just want to always make sure that there is nothing in there that if there is something going on there, then that would prevent me from moving on with vision therapy until that portion is fixed. So it's actually to rule out and not to see if there is, even if there is something that's very small and undetected in MRI, then we can move on with vision therapy. It is when there is something big, but the patient might have not read it or not had it properly explained. So they came to me saying, no, I'm fine. It's just proof, to say, no, this was ruled out, let's move on in vision therapy, versus no, there's something there, go back to your neurologist first and follow up later.
Ok, I'll try to translate. Je vais essayer de traduire. Bon, sur la question de l'utilisation de l'IRM et du champ visuel, au fait, l'IRM, c'est vrai que c'est beaucoup plus la liste de vérification, checklist si vous voulez, quand on prend cette liste qu'elle a exposée, qui va lui permettre un petit peu de profiler le genre de patient ou le genre d'handicap qu'elle a en face. Pour ce qui est du champ visuel, elle l'utilise beaucoup plus pour les autistes, si j'ai bien compris. Mais au fait, l'IRM, c'est beaucoup plus pour voir s'il n'y a pas derrière ces symptômes ou derrière ces dysfonctionnements quelque chose d'actif tel que probablement une tumeur ou hémorragie ou autre chose, un petit peu pour ne pas prioriser les choses, pour quand elle va aborder l'aspect thérapie visuelle, elle puisse l'aborder dans une situation stable et claire pour pouvoir avancer. Okay, so if you have other questions, René, Sarah, Sahel, Hassan, c'est Hassan, non? Qui est là-bas, non?
I have no question, thank you.
Okay. Is there other questions?
Bon, ouais. Oui, j'aurais sans doute d'autres questions à poser, mais je le ferai par mail. I would like to ask you some other questions, but if you don't mind, I will send you an email.
Sure, absolutely.
Thank you again.
Yeah, if anyone else has any questions that you think about later on, feel free to email me as well. And let me actually share on the chat that checklist so everybody can have it.
Okay. Vous pouvez télécharger la checklist, hein, donc si vous êtes connecté. Would you please also send it by mail so I put it as a file?
Yes, sure. Okay, here it
the
is.
handout, please.
And the handout, yes, I will email the handout.
When you will have time, that's not very, that's not an emergency.
Okay.
Just don't forget to do it. That's all.
Okay, sounds good.
Ok, vous avez sur la partie discussion, vous avez un fichier que vous pouvez télécharger. Alors, c'est un fichier qui s'appelle TBI Checklist PDF. Hein, donc, vous pouvez le télécharger, vous cliquez dessus. Et ça se télécharge en principe. Oui, ça se télécharge. Je vais le mettre sur le bureau, comme ça je vais le trouver. Voilà, parfait. Donc, je vais le mettre par la suite sur... Shukran jazilan. Thank you a lot for your kindness. That was a wonderful time to share with you. I hope that wouldn't be the last time. We will see you again and again and again, because we need you actually. We actually you have talked about courses. Mainly, I have done my studies. I'm quite old, in the 70s, 80s, the end of the 70s of the last century, of course. We had Montreal courses from University of Montreal. We had also a lecturer, and we had a kind of knowledge about all kind of units, pedagogical didactic units called psychology. That was an interesting, but we didn't had enough curiosity to go further, because of we wanted to go straight away to the main field, which is ametropia and so on.
Yeah.
But I had the opportunity to do neurophysiology in Britain years later, and that was also a kind of background which has helped me to keep in touch. But actually, I do receive some traumatic brain injury. Mainly for diplopia, so I do a kind of wait and see for the couple of months or 3 months until thing will settle, and after that, mainly we are using prisms to compensate the diplopia, and that's all. So we don't have a lot of background about neurooptometry. I ask you to give this lecture because I have on my mind something which is very important. Optometry is getting quite a big, huge field, and there are subspecialties who are now emerging, such as contact lenses, myopia control, and so on. And the society, the community need to have a neurooptometrist, because there are some issues who can't be sorted out by other people than optometrists. So that's the whole point. My friend René Combe has a big, tremendous experience because he has done his OD in the States, in Boston, New England College of Optometry, and he has also been to the Perkins Institute, so he has quite a big knowledge about that. I hope that he will share with us your exchange communication about this field, because it's really interesting for all the people. Thank you indeed. Je remercie Dr. Almouradi. Je lui ai parlé un peu du cursus. Dans le temps, dans le cursus d'optométrie en Algérie, on avait des modules de psychologie. En fait, ce sont des modules où il y avait beaucoup de neurooptométrie, mais à ce moment-là, ce n'était pas réellement de neurooptométrie, parce que la neurooptométrie n'a vu le jour que, si je me trompe, tu me corriges, René, hein, la neurooptométrie n'a connu un petit peu ses lettres de créance qu'à partir du début des années 90 avec Dr Padula, qui s'est basé un petit peu sur le travail de Siofreda, qui était à Sony, si ma mémoire est bonne. Mais auparavant, il y avait un tas d'informations qui ont été travaillées par les optométristes comportementaux, notamment dans le cadre du COVD. Et bien sûr, quand on a eu cette formation, ce n'était pas une formation qui était très agencée, c'est fin des années 70, début des années 80. Mais c'était parce qu'on était allé, tout le monde est allé un petit peu sur les amétropies, les compensations, la haute contact, etc. Donc, on a un petit peu délaissé ce champ. Et cela me rappelle au fait que la communauté à laquelle on appartient, la société à laquelle on appartient, il y a un certain nombre de personnes, et on a vu tout à l'heure les chiffres de Dr Almouradi, quand elle a mis au fait qu'il y a plus d'1,5 million traumatismes crâniens avec des séquelles visuelles aux États-Unis par rapport aux autres pathologies. Donc, c'est quand même une quantité importante. Et le fait il y a un certain nombre de prérogatives, si vous voulez, ou bien d'aptitudes qui ne peuvent être que chez l'optométriste. Le fait qu'il puisse évaluer l'accommodation, la convergence, le fait qu'il puisse un petit peu investiguer en plus profond les fonctions visuelles, font en sorte qu'en principe, on devrait avoir des neurooptométristes. Alors, c'est très intéressant pour nos étudiants et pour les jeunes optométristes qui viennent de terminer, parce que ça va leur permettre un petit peu d'élargir, parce que l'optométrie est devenue pratiquement un océan. Donc, on a plein de sous-spécialités. Il y a des gens qui se spécialisent dans l'orthoca et le compte de la myopie, d'autres en contactologie, d'autres donc dans la vision binoculaire. Et ce serait intéressant aussi de s'intéresser à la neurooptométrie parce que ça peut aider énormément les gens. Voilà, je te laisse finir et conclure, René, si tu veux bien.
Non, mais je suis tout à fait d'accord avec ce que tu as dit et moi je suis ravi, très heureux en tant que behavioral optometrist, voilà, et en tant que fellow du COVD, bien entendu, j'adhère à tout cela. Pour ce qui est de la neurooptométrie, elle était déjà un peu incluse pour moi dans ce que j'ai appris avec l'entraînement visuel. Et donc, j'ai vu dans la présentation qu'on a parlé de John Streff, voilà, Siofreda, évidemment, que j'ai vu plusieurs fois en conférence dans les meetings du COVD. Et puis, bon, plein d'autres optométristes comme ça qui ont été les gens qui m'ont mis le pied à l'étrier, qui ont été mes pairs. Donc, je suis ravi que certaines personnes s'occupent de ça, tel que le fait actuellement Dr Almouradi. Mais, comment dire, ce qu'il faut dire aussi, c'est que malheureusement, les gens comme ça qui se réclament donc du COVD ou de NORA sont largement minoritaires aux États-Unis. Je crois que ça représente à peu près 10%. 10% of the optometrists only in the States. Donc, c'est pas beaucoup, mais bon, il faut que ça s'améliore. Et surtout, ce qui est intéressant aussi, c'est de dire qu'on doit sortir de l'optométrie réfractionniste, je mets des guillemets, d'accord, pour aller vers donc ce qui est EVM, Visual Training, ou alors la réhabilitation neuro-optométrique, qui semble être le nouveau mot, le nouvel intitulé. It's kind of another words, another concept, another paradigm. Et donc ça, c'est sans doute une très belle chose parce que là aussi, ça a été dit à un moment donné, mais si on n'a pas une vision holistique, if we don't have holistic vision, je crois qu'on est out, on est à côté de la plaque. Voilà. Et je ne peux pas concevoir une pratique optométrique sans voir globalement l'individu avec tous ces paramètres. Et quand je dis ça, c'est avec l'aide d'autres thérapeutes qu'on n'a pas cités ici, mais moi je pense notamment aux ostéopathes. Alors aux États-Unis, il n'y en a pas trop, mais je crois qu'il y a des chiropractors. You have chiropractors in the States? Yes. And I think you work with this kind of guys. Et tout ça, tout ça est important donc, parce que c'est un tout et c'est vrai que c'est difficile de s'occuper de tout. Mais par contre, avoir une vision globale, ça, oui, il le faut absolument. Et là, je suis content parce qu'il y a plein de gens qui sont là et notamment la promotion donc, des étudiants de master de Rabat. Voilà. Et donc, je pense j'espère qu'on leur a transmis ce virus, on va le dire comme ça. OK ? Merci encore pour cette présentation et j'espère qu'il y en aura une autre parce que j'aimerais qu'on rentre maintenant un peu plus dans le concret. Et là, dans le concret, alors là, été ma tasse de thé pendant très longtemps et j'adore ça.
OK. So we'll have
my cup of tea.
Next week we'll have Dr. Comb on a webinar about myopia, what to do, myopia in fact, what to do. This is third part, and there are some COVD traces on each of his presentations. So you are welcome if you would like. Otherwise, you will see it on.
Nobody is perfect.
Okay. So So I wish you a nice weekend and keep in touch. And thank you indeed. Thank you indeed.
Thank you. Thank you so much for having me. It was a pleasure to see everyone, get to meet you guys and talk about this. And yes, it's very important and it is overlooked. Neurooptometry is not mainstream by any means, even with optometrists in the States. Like Dr. Combe mentioned, it's not, and a lot of patients, optometrists don't even refer to neurooptometry. They just do their refraction and they move on. And so it's a problem even here. And, you know, I'm glad that you have interest in it, that you understand the importance of it and the vitality of it to the patient as a whole. And so, you know, thank you very much. شكرا كثير للاستضافة and I appreciate it. And hopefully we can meet again in more webinars.
You should say it in French also. Huh?
Merci beaucoup, but I don't know how to say for having me, for hosting me.
That's enough. Merci beaucoup. Merci à vous.
Merci beaucoup.
Goodbye, and take care. Take care. Okay.
Bye. Have a good evening.
Thank you. You too. Okay.